Hi, and welcome to our session today titled Bridging Local Health Departments to Address Future Health Threats to the MCH Community. My name is Adelaida Pia. I'm a Senior Program Analyst at NACHO, the National Association of County and City Health Officials. Our presentation today was put together along with Dr. Kathleen Sanchez, Director of Research and Evaluation at Los Angeles County Public Health Department, and Hitomi Abe, Program Analyst on the MCH team at NACHO. Next slide, please. Our agenda today will start with our welcome, which we just went through, a brief nature overview, an overview of our initiative today that we'll be discussing, and then stories from the field by Dr. Kathleen Sanchez. We'll quickly go over our lessons learned that we identified during our last year of this initiative, and then next steps in closing. Next slide. So for those of you who may not be familiar, NACHO is a nonprofit serving nearly 3,000 local health departments across the United States. We serve as a voice for and with local health departments, and we conduct a gamut of work on the right-hand side to support local health officials and their staff to create healthy, thriving communities. Over to the right, you'll see a list of the things that NACHO really does to support our local health departments, and that is advocacy, partnership, funding, training and education, networking, and the provision of resources, tools, and technical assistance. Next slide. So the way we describe local health departments are as chief health strategists, and you'll see local health departments are located on the image to the left in the middle there that says public health agencies. And they are in a unique position to really understand the nuances that are unique to the different communities they serve. They serve as being on the front lines, as we know, particularly during this time, during the pandemic, as the front lines of mitigating the impact of the pandemic on their communities. Local health departments work with a variety of partners and in their communities. That's why you see all the little dots, including healthcare partners, government agencies, community-based partners, and so on and so forth. And they work with them in a variety of ways to share information, regularly schedule meetings, establish and written agreements, and sharing personnel and resources. Next slide, please. NACHO's Bridging Preparedness, Infectious Disease, and Maternal and Child Health Project within cities and counties project supports public health and clinical care partnerships at the local level to increase local jurisdictions' ability to protect, respond, and support pregnant people and infants from emerging threats. Our goal in this project is to identify variations, gaps, and promising practices in coordinating responsive surveillance of the impact of infectious diseases on pregnant people and infants among preparedness, infectious disease, and maternal and child health professionals at local health departments. We aim to identify and design tools to support city and county health departments with responding to and managing the impact of infectious disease threats. And we also draw from lessons learned in previous infectious disease outbreaks. Next slide. This past year, so during the 2020-2021 year, this was the disbursement of people that, or local health departments that were included in this initiative. So through the MIP project, NACHO convenes a local health department collaborative to support public health partnerships to increase local jurisdictions' ability to protect, respond, and support pregnant people and infants from emerging threats, as we've discussed. Over the years, we've addressed COVID-19, congenital syphilis, influenza, and other priority infectious diseases. The collaborative is representative of 9 states and comprises 13 local health officials and staff with expertise and interest in the intersectionality of preparedness, infectious disease, maternal and child health, and/or other birth effects. They support us with the goal of this collaborative, which is to identify gaps, variations, and promising practices in coordinating and responding to and surveillance of infectious disease on pregnant people and infants. And that is our general MIP membership. So I'll pass it on today to Dr. Kathleen Sanchez, one of our MIP members from the 2020-2021 cohort, to discuss some of her stories from the field.
Thank you, Adele. Along with my MIP colleagues from around the country in 2020, I became very engaged with the goal of the group, and that is to improve the coordination of our response and surveillance activities in terms of infectious disease outbreaks or other emerging threats on pregnant people. Our meeting sessions were always productive and often left me wondering whether the idea could be tested in Los Angeles County. So by January of 2021, I made an attempt at the local level to take this idea and spring into action. Next slide, please. First, I'd like to share a bit more about my role. Within the Department of Public Health in Los Angeles County, I'm working with the Vaccine Preventable Disease Control Program. In addition to my current research and evaluation activities, a core responsibility that I have in the program evolves around my role as the program's quality improvement specialist. In collaboration with our nursing and epidemiology units, I'm responsible for 2 maternal and child immunization projects, the Infant Pertussis Follow-Up Project and the Perinatal Hepatitis B Transmission Prevention Program. Both of these programs involve contact with prenatal providers to ensure the use of best maternity care practices as it relates to infectious disease prevention as well as management. As the QI specialist, I also collaborate with colleagues from MCH and CAH because many of their perinatal providers serve Medi-Cal eligible birthing persons through the Comprehensive Perinatal Services Program, or CPSP, or through the newly launched African American Infant and Maternal Mortality Doula Initiative. Each year, also during influenza season, I collaborate with the Emergency Preparedness and Response Program. With these colleagues, we do targeted messaging to pregnant persons to improve influenza vaccine uptake. So as I reflected on this professional network that I have within the department, I realized I had a local MIP configuration within my reach, and I could attempt to gauge interest in creating a formal MIP work group with them. Next slide, please. I decided to start my journey of determining if there was any interest among my colleagues with the strategy of asking questions, engaging colleagues, and drawing connections to MIP with their current activities, as well as to, if after those conversations, to follow up on their interests with the idea of a local MIP activity. Given my existing work was closely connected with MCAH, my colleagues from the Doula Initiative expressed interest and participated in a NACHO MIP activity. From there, I was referred to our home visiting program team, which was housed within MCAH as well. These conversations with this team gave me insight in the impact of our Safer at Home initiatives during the pandemic on their routine activities, as well as how their services would need to evolve to meet the needs of birthing persons who may have tested positive during pregnancy or had someone else in the family, including an infant who tested positive or experienced some sort of loss at this time. In a sense, these home visitors would become recovery first responders whose scope of work would probably expand under these circumstances. From there, my journey continued on to my colleagues at the Emergency Preparedness Program, specifically within the Community Resilience Unit. Like my conversations with the home visiting team, the Community Resilience Unit colleagues expressed interest in learning about the formation of a local MIP. However, it was clear that COVID-19 priorities had stretched this very small team that historically took on only grant-funded projects. This was what we called a small but an important win. Also during this time, I also learned that our acute communicable disease control program was involved with MCAH issues. Specifically, this program managed the collection and coordination of data on COVID-19 positive pregnant women and their infants. In addition, this program would be responsible for coordinating medical care referrals to our internal children's medical care services program, as well as collaborating with community partners as they did with Zika related cases back in 2018. The collaboration grew than initially envisioned and would always require that we make a priority to deliver a wide range of support services to pregnant, postpartum, and lactating individuals. Next slide. As I reflected on these conversations with my colleagues and connections, it became clear that many of the key ingredients were very present to grow this idea of a local MIP, but a collective commitment to prioritize this was becoming clear that it was existing on relationships and shifting priorities within each program. Through a continued dialogue with Adele and my NACHO colleagues, as well as those from AMCHIP, led to the idea that a more sustainable approach to center the needs of pregnant women, birthing persons, and children during emergencies would require an institutional infrastructure. For me, this infrastructure may have a greater chance to ensure that a health department could be efficient as well as effective in assessing and delivering quality services. Consequently, what we proposed is an emergency preparedness response led MIP incident command structure, which on the slide is labeled EPER led MIP-ICS. And this idea was tossed around as a potential sustainable approach and is illustrated on the slide. So embedded in this idea of infrastructure, it expands the capacity of the health department to integrate annual simulation exercises to mitigate disasters, as we typically did prior to COVID-19 in my health department. But with a specific MIP-ICS, these exercises could be tailored to address the needs of pregnant women, birthing persons, and children in a more comprehensive way. In addition, health department staff within MCH, the VPDC, or the immunization program and other health departments could be cross-trained on a consistent basis to participate in these annual exercises and stay on top of best practices and innovations in the field. Lastly, this approach could transform the flow of data collection with an equity lens on issues related to the surveillance of outcomes, adapting to new information as it becomes available, and nurtures dissemination systems to be inclusive across programs and with external stakeholders in real time. Why is this important? As we've learned from COVID, urgent messaging about testing, vaccine availability, food and shelter resources need to flow from as many different sources as possible. Therefore, the idea of centralizing information through an equity lens hopefully would reach a diverse audience and minimize duplication of efforts through a streamlined, coordinated process. This proposed sustainable approach has the capacity to keep this vulnerable population at the forefront of everyone's mind in a proactive manner, rather than when poor outcomes such as higher rates of hospitalizations emerge. Finally, as we've learned early on within the pandemic, the data highlighted the central role that women play in keeping the economy thriving as essential workers, and the multiple roles we assume at home during emergency conditions that impact recovery timelines. We do have the capacity to build back better, and the creation of a sustainable MIP framework is, in my humble opinion, a promising activity for health departments to lead the way in that direction. Thank you for your attention, and I turn the presentation back to my colleague Adele to share our lessons learned. Thank you.
Thank you so much for that, Kathleen. As Kathleen mentioned and was a part of, the MIP work group last year really came together to discuss how they are working to bridge emergency preparedness, infectious disease, and maternal and child health folks to mitigate the impacts of, for last year, COVID-19 on pregnant people and infants. We came up with a couple of lessons learned that we wanted to share with you all today. The first one is to really make collaboration a priority. Our members have shared that prioritizing collaboration and planning for future public health threats has been a challenge across local health departments and really across the nation. The overwhelming burden presented by the need to address the pandemic has limited local health departments' ability to collaborate, plan, and prepare for other current and future public health threats. The COVID crisis has exposed the lack of dedicated resources to MCH populations during emergency preparedness and emergency crises, and made it evident that the MCH population should be included as a priority item in any and every emergency preparedness plan. And thus, we found it a big lesson learned to make sure that collaborating is a priority across the board. The second lesson learned we identified is focusing on small wins. This effort to collaborate across local health departments for emergency preparedness and prioritizing MCH populations can seem like a daunting task. Identifying smaller scale activities first can increase momentum and help make the process more approachable. For any local health department, it is not possible to take on a large scale changes right away. By leveraging small wins, local health departments can take steps to strengthen their internal collaboration and processes to ensure that the needs of the MCH population are addressed during future emergency planning. Additionally, we also established establishing organizational-wide infrastructures. So, as MIP, former MIP member Dr. Kathleen Sanchez just shared, she started replicating this collaboration model at her health department. From her experiences so far, she learned that the importance of moving beyond relationship-based pathways as staff role may change over time and is an unsustainable approach. Changing the infrastructure of local health departments' emergency preparedness processes will help ensure that these collaborations are continuous and that staff across departments are working together to enhance MCH populations during public health emergencies. Infrastructure changes could include building a preparedness team with designated staff from various departments that meet regularly to review and revise emergency plans, almost like an internal command structure. Next, we also had the need to foster information sharing, strengthen internal collaborative systems and partnerships, and establish goals to address public health challenges. And lastly, we also talked about continuously adapting and improving planning efforts and communication strategies from previous infectious disease outbreaks to take a proactive approach. So these were the lessons learned that we identified as a part of our work group last year. Next slide. We want to thank you so much for tuning into our sessions today. I believe our contact information is listed somewhere on this presentation and probably below. If you would like to reach out to us, please feel free to reach out to me, Adela Pia. My email is presented on the screen. Thanks so much.